good morning, everyone. Hope you're doing well. I don't have any PowerPoint or anything like that. I just wanted to bring to you the latest information that I have going on in the federal government and in the state government, so you're better prepared, and a little bit of sneak preview of some things coming down in the future. And I know that Marlene covered a couple of these items. I just want to put my spin on them as we go through them quickly. On the federal side, the biggest thing is really the implementation of the National AIDS Strategy. And we've been involved in, I've been involved in the last month in particular with meeting after meeting and phone call after phone call of what a state plan would look like. Because part of the National AIDS Strategy calls for state plans. It's not mandated, and there's a consultation in Washington, D.C. on April 14th, which is next week, to determine what a state plan should look like. So just as a heads up, and this group would be a very, very key and important group, obviously, in determining what would be in our state plan, what is a state plan, what does it look like, if states have patient care plans and hepatitis plans and prevention plans, would the federal government be interested in another plan? We're trying to convince them not to go down that road. The other thing that's kind of tangled up in that, as Marlene already mentioned, is our very, very successful submission of the E-CHIP grant, or the 12 Cities Project, or as one city put it, the 12 chip, where and this is important for this group, and I know it's been covered, but I can't tell you how big a deal it is that the feds are going to make a change. They're going to make a change in how we distribute money and we fight HIV in the country. And there's definitely going to be a movement to concentrate more resources and more firepower, so to speak, on high morbidity areas so we can have a result in reducing new infections in the United States, and therefore in our own state. Now, we don't have the number yet, but we're convinced that when the shift occurs, and we're going to have the number shortly, probably in May, that we will be the biggest recipient in the United States of new funds for prevention. And that's the best news I can bring to you today. And it's a long story on why, but the bottom line is there's about $300 million, 300 plus million in the United States in places around the country. And the way it was allocated back in the 80s in particular was heavily favored on the West Coast and the Northeast. And there's a correction coming, and the correction will kind of move this money to the South, and we're the biggest player in the South. And so what's supposed to happen is that we're actually supposed to get the number in May. So when we write the grant this summer, we'll actually know how much we're applying for. There may be as much as about $51 million being moved around the country. And so we would get a portion of that, which no matter how you look at it, is going to be a significant amount of money. So the thought process here, the thinking, what do we spend the money on, what science-based interventions, how much more testing, and on and on and on is critical. Now, again, as another preview, and I know it's been covered, is that it's just not a blank check. That there will be very strict conditions and strict direction on where they want us to move the money and what they want us to buy with it. Second kind of big change, it's very unclear, again another sneak preview, is that there's probably a change coming on the federal side related to school health and HIV. And it's unclear what the final outcome will be, but the money at CDC that funds Dade County School Board, funds the Department of Education in Tallahassee, the Broward School. There's something that's going to change. And if the outcome could be exactly the same, that the same recipients get the same amount of money, but it doesn't look like it's going to come from the Division of Adolescent and School Health anymore. In fact, that division may be changing in the Center for Disease Control structure, and that's why the money is going to be moved away. And I believe that's planned for 2012. So we have to look out for that. There's several school systems in our state that get CDC money for prevention for AIDS. There's our own office in the Department of Education, and we have to follow this very closely to make sure that those programs continue to exist. The other lurking thing, just very quickly, is the federal government shutdown. We have been in some emergency meetings the last 2 days. We have federal employees in our state that belong to the Centers for Disease Control, and they can't come to work if the government shuts down, and their responsibilities. You can imagine the domino effect of what happens if the government shuts down. The good news about the flow of money is we kind of averted a fairly big crisis. Last week we received $57 million from HRSA, from the Ryan White Care Act. Now, April 1st is the beginning of the Ryan White Care year. We got $118 million last year, and we still had an ADAP crisis, as you all know. I'll talk about that in a second. And we were very worried with no budget, how much money was the feds going to send to us, so we don't have another crisis on April 1st, because we have to buy over $7 million a month in pharmaceuticals. Well, based on the current continuing resolution, they were able to send us $57 million. So we have it, it's being spent on drugs, our portion of it, and that's approximately 48% of our grant. And that would theoretically last us to October. Now, the feds have to settle this issue, or Congress has to settle this issue. We're hoping by midnight tonight, because if they don't, then we've got big problems. The other good news about the lack of disruption, or preventing disruption, is that on January 1st, we received 25% of our CDC grant for prevention because of a continuing resolution. Well, guess what? That money actually ran out or expired on March 31st, which was 7 days ago. And we did not have any more. They did not send any more. Then yesterday, they sent 25%. So we have enough money in our grant to last us to June 30th now. That's 6 months of the 50% of the grant and 50% of the calendar year. This is just no way to do business. It is just unbelievable. When you have contracts for millions of dollars, and now our state, I'm going to say some other things about our state, but one of the things that's really good in the Department of Health is our budget and contract office allow us to do a lot of things when the check is in the mail. There are other states that say, you don't have the money from the feds, you shut down, because they won't take the liability chance of something happening. So the National AIDS Strategy, kind of the E-chip, the 12-city philosophy, the shutdown. We have partial money from the feds to both in Ryan White and prevention. And then a couple of other big kind of federal things we're working on and trying to be a leader in is the discussion around the country about trying to reduce new infections with MSM, the connection to PrEP. And, everybody wants to make progress here. No matter how you slice and dice the data, the MSM cases drive up the incidence numbers in our state. And we have tremendous numbers related to co-infection of HIV with syphilis in our state and around the country. So places like Fort Lauderdale, Miami, and the big MSM centers in our own state, we have to make when this new money comes, there's going to have to be a commitment and a push to really drive these numbers down if we're going to reduce numbers in our own state. Now, the other thing that's connected to all of this is the actual incidence numbers. Marlene may have mentioned this. You may recall in Mexico City at the International AIDS Conference, the CDC stood up and said we have 56,000 new infections in the country because of a new technology and a new methodology. And we did our calculations and said we have about 5,500. So the whole country, there's a lot of headlines about that. And then there was supposed to be an incident number for 207 and 208 and 209, and that's how we were going to track this in the United States. Well, CDC changed the rules and have been holding the incidence numbers for 207 and 208 and 209 for years now. They promised us they're going to release them this year. And furthermore, they're going to release all the years, including back to 206, which the number will change. So we all have to brace for that because the media will have a ball with this. Well, you told us there were 56,000 new infections in 2006. Why are you telling us there's whatever number it's going to be? 50,000, 60,000. And then what if the number goes up in 07 and down in 08 and up in 09? So the incident staff in my shop is working hard with the CDC because guess who the biggest player in the country is for incidents? State of Florida. Why? Because we have the largest counseling and testing program. And the major incidence calculation is the blood specimens that are taken and sent off to the laboratory in New York State where the STARS test is done. So we don't have a bullet for you yet because we don't have the information from the CDC like any other state. But it could come and it could come quickly, and it probably could be a pretty big headline like it was last time. And then really, I think I already mentioned the other thing is we're anxiously waiting for the draft of the 2012 announcement. We think we know some of the things that will be in there that will change in prevention in the United States. We were told at a briefing in DC last week that there's going to be more flexibility built into some of the cooperative agreements where we'll have flexibility of spending money in some categories that we weren't able to do in the past. But we were told the announcement is delayed. We were supposed to have it by now in April. And we were told maybe mid-May, so maybe another month and a half. Now, on the state level, we have more change than can possibly be described. We have a new state health officer, a new Surgeon General, Dr. Frank Farmer, who started on Monday of this week. He's a long-term physician, military background from Daytona Beach that has been described on several occasions as one of the nicest guys you'll ever meet. And he has been that way the first week on the job, but I don't know his positions on our issues yet. There's a briefing next week, and so we'll know more on kind of a face-to-face. We have a new governor's office that has a whole set of different rules that we were not accustomed to. There's an Office of Fiscal Responsibility. So rules, contracts, asking for money from the federal government, everything we do must go through that office before we do it. It's not ask, it's a get approval. And so I tell you all this because this is going to be around for a while, and the way we do business is going to change because we have to conform with what we've been asked to do. We think we averted a number of crises right after the election when millions of dollars of contracts were held up, billions of dollars of grants were held up, a rule was held up, and you read the papers on other programs, and things like bridges were held up from being built and pavement on roads because you had to go through this particular process. The good thing about that process is we've educated some people along the way. And every battle that we have fought to get something done, we've won so far. We could lose some in the future, but we're batting 100% right this minute. The legislature last night passed the health budget, the House budget and the Senate budget. And now today it goes to conference committee. There is $3 million increase for ADAP in the Senate and $2 million increase for AICP in the Senate. There is no increases in the House. And so the normal procedure is that members of the House and members of the Senate are selected. They go into conference committee and they hash it out. And they come out with a real budget. And that's what they all have to vote on, and the governor has to sign by the first week of May. There are $3.8 billion of reductions in those budgets. So there are potentially other AIDS reductions in those budgets as we speak. And it will not be clear until the conference committee is close to finish with their work and we get our hands on the Appropriations Act and we go line by line to determine where the increases are or where the decreases are so we can make a coherent statement about the impact to our program. In one version of all this, there's about $1.6 million of reductions in AIDS programming and $5 million of increases if it's stopped today. Now, as you heard from me before, I call that direct increases and direct. In this particular year, we have to be very concerned with indirect reductions, and those are gigantic. What I mean by that, if there's 400 more million reduced from the Department of Health, or millions reduced from Medicaid, 38,000 from Jackson Memorial Hospital in Miami. So they're not happy, as you would expect. It also reduces about 240,000 in a category called HIV prevention for minorities. It reduces major millions from the Closing the Gap program. And I'm saying this because it's halfway through. None of this is official yet, but that's what's in bills as they pass around and they finalize conference committee. Let me just touch very quickly on the ADAP crisis. As many of you know, we did not have enough money to make it to the March 31st end of the Ryan White year. We put a Band-Aid together to get about 6,000 patients their drugs from Well Vista, a company in South Carolina. The pharmaceutical company stepped up to the plate, provided drugs at little or no cost to Well Vista, and well over 10,000 prescriptions received in the state of Florida to patients who could have gone without their drug if this was not done. Those patients are being transferred back to the existing ADAP program. There's approximately 10,000 of them total. And the money that I referred to, the 57 million, a portion of that will now pay for their drugs as we put them back into the existing ADAP system. And depending on our numbers from HRSA that we're waiting for because of the government not having a budget, we'll know shortly if we have enough money for the existing patients for the next 12 months, the rest of the year. I'm somewhat confident we do, but I can't make a decision until we get all the numbers from the feds. And then finally, and there are still about 3,900 people on the wait list. The plan there is that if we get additional money, which is in the pipeline, that we could start to take some people off the wait list. But until we get the numbers out of the state legislature, the numbers out of HRSA, there's even increases in the continuing resolution, the final 2011 negotiations up to $70 million. Will they happen? Maybe not, probably not. And then there's increases in 2012 budget. But it's very, very unclear until something passes and we can get our hands on those numbers. And then just to end on a little bit of a more positive note, in our work here, there is all in this environment of changes at the state level, changes at the federal level, there's still some unbelievably great work being done. We are a very major player in the work with the Kaiser Family Foundation as it relates to Greater Than AIDS. There was a major event, as many of you know, I think Evelyn attended, at the Heat game, the Miami Heat game down at American Airlines Arena, was 2 weeks ago. Marlene announced that we passed over 400,000 tests in 2010. That's another all-time record with how many rapid tests, Marlene? 203,000 rapid tests in the state of Florida. That's unbelievable. And then on the way down, I really got, you know, sometimes you get an email that you go, oh God, and then you get an email that says, wow, got a wow. Our vital statistics office sent me an email on the way down here with preliminary information about the number of people who died in the state of Florida from AIDS in 2010, which is very early for us to get this in April. It's kind of early, so. But as you know, we were relatively pleased the last 3 years. We had the first decline 3 years ago, 16% or 13%, and then another smaller decline, and then in 2009, a third decline, which means that's a trend. And when we started this in 1995, before protease inhibitors, 4,500 people died in the state of Florida from AIDS. And in 2009, which was our last data up until recently, we were at about 1,300, a little under, around 1,300. And it had come down from 1,700. Well, the email I got said that if the preliminary numbers showed another 16% decline for 2009 and just almost under 1,000, which is just phenomenal, And I don't want, that's not released, it's preliminary, but I mean, people have to get feedback on the work they do. The testing program, this early testing, is definitely paying off. The linkage programs that everybody runs is paying off. And that's why we're working real hard to try to get the money and the drugs, because we know that people, if they'll stay in care, stay on treatment, that the results are coming in. And tremendous reductions in African Americans in particular on these rates. They'll be official later this year. But as far as our planning group, you need to know that things are going in the right direction. I think I'll stop there, and I've said kind of a lot all over the map. Is anybody wanting a clarification or follow-up? I just can't tell you how much change is going on. Bobby?
Could you send this group the graphs that we have existing for the decline in death rates?
Mm-hmm.
Thank you.
It's on the website too.
Mm-hmm. We'll get that. Anything else, anything you're hearing, or anything I can advocate for at a different level that's causing stress or pain in the field that I can help with.
Do you know any more about, which I'm sure, I don't know if you know yet, are they gonna restructure?
Department of Health?
Yeah.
I think the answer, Charles, is yes. It's not a bill yet, but every indication is that the House and the Senate want the Department of Health to be streamlined, want reductions. There's the big plan out there of hundreds of millions of dollars being reduced, children's medical services being privatized and moved to ACA, you know, very, very major. 58 bureaus being collapsed to 16 bureaus, 11 divisions being collapsed to 4. In the plan, our bureau, which is the second largest bureau in the current structure, would be collapsed with 4 other bureaus. You know, so we're talking about major, major change. We talk about it every day. The feeling is that the legislature will send us the message very shortly, either in a bill or through the appropriations process. If they do it during the appropriations process, then it would be a fair amount of proviso language. If they feel like they have to put it in a bill because it changes the structure so much, including one of the proposals of eliminating the Surgeon General and just making it a state health officer and secretary of the department, then I think they'll put a bill together. But yes, I'm glad you brought that up because, again, with that kind of, if that happens after the session, there's going to be a lot of time and energy. And in that plan, just so everybody knows, we would be mandated to reduce our staff by 8 people. That's in the plan. And these are primarily positions that are federally funded. We wouldn't be losing the money, but we're mandated to cut positions by at least 8 people. And I think our division was targeted for 24 people.
Now, how can you, and I'm just being naive here, but how can you not lose the money? If they're federal positions and you have to cut them, how can you not lose that money?
Well, we would redirect it into other programs.
So that money's not mandated for those people?
It would be mandated for those people in the cooperative agreement. And then because of the reduction, we would reprogram it primarily probably in the counties or whatever category we're legally. If we had to cut, as an example, 2 prevention staff in Tallahassee on Marlene's staff, then that money would obviously end up in prevention, buying test kits, buying condoms in the field, you know.
Okay.
Because it wouldn't be cut at the CDC level. And that would play out in all the grants.
Given that Florida has the largest testing program, is there any discussion that we need to scale back some? That we don't need to be the biggest one spending all the money in the nation?
I think we need to wait for that question until we see the 2012 new cooperative agreement. Because the other states are actually investing and catching up quickly because of the rapid test in particular. And that's one of our biggest expenses. We get a lot of bang for our buck that doesn't cost us anything. We don't pay the family planning program any money to do how many thousand tests. We just pay for the test, period. We don't pay the maternal and child health program to do the test or to counsel anybody, but we just pay for the test. And so that's why part of why other places actually have to pay for that along the way. I think Bobby's asking a good question though. When we see the draft of the 2012 cooperative agreement, and if we see a huge more emphasis on testing in there, we have to huddle up and say, are we there already? Or do we have to make a bigger investment? If we see a real strong language about putting more money, as an example, into the 6 big cities in our state, if we see a strong language in there about certain level of intervention. We believe there's going to be language in there, as an example, to increase prevention for positives. Okay? So that's why this group, and we have to sit around and go, okay, what are the interventions we want to use, and who do we want to do them, and what places in the state do we want to execute them? And so I see prevention for positives. Testing is a good question. I don't know if we have to scale up too much more. I would look for people from Pensacola to Key West to tell me that and say, you know, we really got it covered. And community health centers keeps coming up and coming up and coming up. We really need to have a meeting at a high level with the Community Health Center Association in the state of Florida. And I think there are some community health centers in our state, there's over 40 now, that do a very good job in testing, and a very good job in a medical home for HIV patients, and there's some that just don't do much at all. They're a good community health center, but they're not heavily invested in the HIV business. And depending on what's in that language, we have to determine if we need to make an investment there.
A while ago, there was a big splash in the media concerning pre-exposure prophylaxis, giving medicine to people to keep them from becoming infected. Is there any discussion about the funding? I mean, basically what we've got is we've got an intervention, but we're telling the public we can't afford to do this, especially if we're targeting men who have sex with men. It sort of says, we know what works, but we're not going to give it to you. We really don't care about you.
It's close to that. The science is there that it probably works, and it probably works for MSM to some level. The FDA has not approved Truvada as a usage for that particular client under that circumstance. And as you all know, we can't use a federal dollar today on treating a negative person. We have fought for 10 years, HRSA, to let us use a Ryan White dollar to treat an exposed baby. And they said no. So we have to cough up different money to help our perinatal program so they can reach into CVS or Walgreens and find drugs so we can treat an exposed baby for 6 weeks after they're born. So yes, you're completely correct. There is no funding source for it. I have been in 2 meetings about who would pay. And the feds held a meeting 2 weeks ago in DC, and 3 insurance companies came and said if the FDA approved the treatment and the CDC wrote guidelines that said it was effective, they would strongly consider paying for it.
It would save them money in the long run.
Right. And you know, again, just for the concept here is to give gay men at this point, because that's the only ones that have been studied, PrEP, who are HIV negative and are at high risk, and and meets the criteria that would actually prevent them from getting HIV. Yes, ma'am.
Jumping back a little bit back on the testing. Clearview is a new testing type that has been piloted here in Tampa and will be coming to Orlando soon, this month, next month. Will that testing type also be where you're only spending money just for the test? Like you just said, you only have to pay for the test, you don't pay for all the other stuff, because if it's doing well, then it also is going to increase the numbers of testing.
Yeah. Marlene can answer too, but the short answer is the arrangement, we have thousands and thousands of testing sites, and each one is negotiated a little differently. The majority of them, this is the good news, the majority of them are places where we don't pay anything for the labor, but we pay for the test. So we go to a facility, and it can be a pharmacy, the back of a pharmacy, a jail, community health center. And let me just give you 2 quick examples. in the family planning clinics that I mentioned, and in some cases STD clinics, and even some jails. We pay for the test, period. In the emergency room down in South Florida somewhere, we go to them and they say, we'd love to help you, but paying for the test isn't just good enough. We can't afford our nurse or our emergency room tech. So if you pay for them so we can hire somebody else, we can do your testing program. And that plays out all over the state. And so we have, and it's the answer when we want in there so bad because we know it's the right venue, then we come with a little bit more so we can get into the busiest emergency room in the state of Florida. But when we really think it should be routinized, then their staff should absorb it. And we'll pay for the test, we'll take the test kit, you can send it to the lab with blood, whatever specimen. And we're pretty darn successful in both models. But it's a tailor-made case by case.
So do we see Clearview possibly taking over the OR equipment?
Right now, we give providers a choice. There were basically 3 rapid tests that we were giving providers a choice of. It was OraQuick, Clearview, and Unigold. There were only 2 places in the state that wanted to use Unigold. One was the Citrus County Health Department, the other was the Palm Beach County Health Department. They have both since switched off of Unigold, so we have nobody in the state who wants to use Unigold. So we pretty much have stopped purchasing that. It's just not cost effective to have, just a few kits. So pretty much everybody uses either OraQuick or Clearview, and the choice is theirs. The trend has been moving towards Clearview and away from OraQuick in a fairly big way. So, in fact, it shifts every single day that I can't even tell you what the percentage is today. It's still a little bit more OraQuick, but that's changing rapidly. And some people like Clearview better. We've had people that actually switched to Clearview, but then went back again the other way, and vice versa. Clearview can't be used oral. Clearview is only finger stick. That's a good thing, I think. We think that's a good thing, just in terms of accuracy. So it's really still a choice. Clearview is cheaper for us, though. That is about almost $2 a test cheaper. So shifting in that direction is saving us money.
And I just want to say one quick thing about hepatitis and then sit down. We got a lot of challenges with the future of hepatitis in our state and around the country. We now have a FDA-approved rapid test. We don't have any money for it. We had access to $1 million of vaccine at the CDC for the last 4 years. CDC has shut that program down. We do not have access to free vaccine from the CDC 317 program. And then we have 2 very expensive drugs in the pipeline that are close to FDA approval for the treatment of hepatitis C that has a high effective rate than current drugs used. And we have very, very tough policy decisions ahead because in the good old days, when an FDA-approved drug came along for the treatment of HIV or hepatitis, we said, put it on the ADAP formula. Well, that doesn't look very promising right now. And so in asking for money for both testing for hepatitis C, vaccination for hepatitis A and B, and treatment, new treatment drugs in this environment is really, really tough. Now we know the insurance companies and the VA hospitals and those should be able to pick that up and Medicaid. But for the people that don't have health insurance, which are approximately 4 million people in the state of Florida, we feel a responsibility and want to do something about that. So we're beginning the talks about how to handle those kind of demands as they come very much in 2012 and 2013. Appreciate your work, appreciate your time. You guys have done a fantastic job. I'm very proud of the state in the area of prevention. We're in a tough climate, folks. I don't know what else to say. Everybody here knows that. And if we can hang in, I think the economy is turning around a little bit, and we'll try to provide the resources so everybody can get their job done. So thank you so much.
Tom, not knowing if we'll get another chance, but we want to also thank you for your leadership and representing us throughout the country and for all the things that you've done. So we truly appreciate that. We're going to do a brief synopsis of what went on at the Leadership Summit. So Bobby's going to begin.
Well, I didn't know that. For those who are new, there's an annual HIV Prevention Leadership Summit that's held around the nation in large cities usually. And the idea is to bring people doing this work in prevention planning together once a year to talk about the trends nationally. So we get to find out and talk to people, okay, you live in Wyoming, what are you guys doing different there? What do you see as the effect of in Hawaii? You know, we, in different populations than we have for large groups here. In other words, California brings a large Asian Pacific Islander component to the meeting, so we get to hear their concerns. It's a much different arrangement in different parts of the nation. So this is a report for Charles went, I went, several people from the Bureau went. This group nominated to send Valerie Mency as a representative. She's not here right now, but her report is in your packet. I have a report in your packet as well. It's on the left-hand side. This year I've been having a personal interest in linkage, so I tried to go to all the linkage meetings they had. And the answer to most of my linkage questions was use your Part A dollars to hire a linkage specialist. Well, I don't have Part A. What money am I supposed to use? And the other thing that I found, and I'm guilty of this because I didn't submit something to participate in or to be a presenter, but almost all presentations were from large metropolitan areas. In other words, the rural community was not well represented from the presenter side. They were represented in the visitor side and the partaker side, but not in the presenter side. So the first linkage breakout I went to, they talked about HART can now expect to add an additional 35 years of life, the highly active antiretrovirals, as opposed to the fairly active antiretrovirals, which means that you have a lower community viral load, which means less transmission. Another one that I went to was the plenary session, and they talked about moving the money from the rural communities to the large urban centers. Another one was on rural issues, and they pointed out that getting people gathered together for Debbies and Ebbies across rural or frontier states like Wyoming or Montana or Iowa or Alaska, where you've got to fly over a mountain through a snowstorm to get to participate in, some Debbie program, is a little bit difficult. We're currently, the Alachua Health Department is currently participating with a lady from Dr. Marhefka from the University of South Florida right next door here. They're going to be starting a video phone healthy relationship class where people from Alachua, there'll be one person sitting in front of a video phone, another in Alachua, somebody in Gulf County, somebody in Pasco, somebody in Highlands County, and there'll be a facilitator here at the University of South Florida. And instead of getting together physically, it'll be a virtual class. So we're exploring that option. Another point that I found to be interesting was one study indicated that there was a 92% reduction in heterosexual HIV transmission after the initiation of antiretroviral therapy. That's a big chunk. So one of the themes for this whole meeting was medication is prevention. In other words, we're going through PrEP, we're going through treatments, we're going through adherence, we're going through all those issues. That is prevention. If you get that community viral load down, that's an important thing. So in your communities, you may want to start looking at what is my community viral load of the people we know. You know, I know you're not going to know everybody's viral load, but you may, that may be something we want to address on a statewide basis. What's our state viral load look like? Can we look at it by areas? You know, can we look at it by clinics? Is one clinic doing a better job than another? Another issue in linkages is that 1/3 to 2/3 of the people with HIV in the United States are not in regular care, and half of those people don't know their status. So again, we're trying to link people into those systems. One place that has an idea for their linkage is, they call it their red carpet plan. You get, if you say, I will participate and I'll be linked to care, they will get you an appointment within 24 hours of being told you're HIV positive. So they've got some slots set aside, and then they have an idea of how many people they test positive on a regular basis. And they've got a slot in their clinic that say, if you'll come in tomorrow, we'll bring you right in, if you're willing to cooperate, which I thought was a nice idea. That was a useful idea, I thought. And another section that I went to was working with gay men of color. It was a breakout session. And this is out of a report from Hutchinson in 2007 on researching MSM beliefs. They looked at Black, Latino, and white. And this is revolving around drug companies having a cure, drugs do more harm than help, HIV does not cause AIDS, and HIV is man-made. Now this is the group that everybody agrees is the fastest growing group in the nation. The MSM community is really driving the epidemic.
And they had found positives, and it was working really well. But they were able to, when they did find someone positive, they were able to put them right back in line, which I kind of found amazing, because you just told this person they were positive and they went back out and got back in line. And then they would take them to help them find services afterward.
What area was that in, Charles?
Pardon?
What area was that?
I can't remember. It was like Chicago. Was it Chicago, or because it's one of the UCHAP cities? I think it's Chicago. I'm not sure. And but it was really interesting. I mean, it was something novel, and it was something different. And I think sometimes that's what it's going to take now, because I think that we are testing, especially in Florida. We do so many tests, but I still think there are pockets that we're not getting because they don't feel like as though they're at risk. When we were, I presented at the leadership summit with Charles Collins from the CDC. We presented on Debbie's. Guess what side I was on? And it was really a great conversation, because him and I hadn't met each other. We talked to each other. There was a breach between him and Debbie's. I mean, he's always been really big on Debbie's, but that was the line that the CDC told. I think they started in like 2006, right? 2006, 2007, they started pushing Debbie's. He is pushing for more of a holistic look at gay men's health, at everyone's health. And he's wanting to routinize HIV testing, pretty much like we do here. But he wants to put it into everything, and so he wants to do STD testing, blood pressure, diabetes, HIV, just, rattle it off and make everyone see that this is just something. For the first time too, he's talking about, we need to talk about sex, which is something I know that all of us don't find that surprising, but when you're in the CDC, when you're listening to the CDC and they're saying, we need to talk about sex and gay sex, that's a little bit risque for them, being that they just came out of the last administration that really kind of pushed abstinence only for programs, for big programs, and so they had to push it, even though they knew, and even though there was evidence that abstinence only was not working, has not really worked well. So that's something different. And of course, the big talk also at the Leadership Summit was about the HIV and AIDS strategic plan. It's becoming more and more ingrained, and I think it's, well, I don't think, it's going to become more and more ingrained in everything that we do. We talked about it yesterday again, in a meeting with Ron Belisari, and they were talking about how they want the funding to follow the policy. They're really taking this policy, you know, very serious. And I mean, that's why I was saying around the table yesterday, if you haven't read the policy, you should read it. You know, when U.S. didn't have a policy, before we get any other country money, they had to have a strategic policy before we, as a country, would give them money. But we never had a strategic policy. We just made them have it. Which I think is the height of hypocrisy. But this was you know, it was really great. It was a great procedure to go around, hear this. I mean, the thing about it is it's got prevention in it. It's really, really good. It's got, you know, it talks about HIV, it talks about care. So that's why I'm saying it's a very good read. But when we were sitting there, they're talking about, just like Tom was talking about funding going to the bigger cities or bigger states, and Florida may get more. That's actually in the policy where they're starting to talk about where we need to be attacking the virus if we're really going to make impact and inroads. And people say, well, why is there so much? There was an argument about why is there so much, I think Tom said, are we failing in the big cities then because we have so many cases? No, we have a lot of people. You know, so when you have a lot of people, you know, if you have 1 million people in Florida, I'm just using it as a round number, and you have 1,000 people in Iowa, guess which one's going to have more burden? So that was the last thing that was the last thing that I was talking about. They did talk about e-chips. Miami is one of the cities that's is an e-chip city. I have not been able to go to the meetings in Miami because it seems like every time they have a meeting, they just pick the day I'm out of town. But I have a meeting about it on Monday. But the great thing is that I think this is going to be a roadmap for some of the stuff that we're going to do in the future, and it's the way that prevention and education is going. I really think from some of the stuff that I heard around the tables or around there, that CBOs are going to have to change. They're going to have to morph a little bit. You're going to have to, I believe that you're going to have to do more than HIV and AIDS if you're going to want to, you know. I think, and I can say this with utmost confidence, I do know that the CDC and HHS feels that CBOs are a very important part of the struggle of HIV and AIDS. And they believe that, they see that, they know that, and they don't want CBOs to go away. But they do know that CBOs are going to have to change something. And that's just the way it is. But I mean, working as someone who's worked in CBOs for a long, long time, we always move. We always change. You know, we made the change when they did the debits. Whether we liked it or not, we made that change. And we'll make the change whatever they're looking for with a strategic policy. So those were the things that I picked up. I thought the summit was really well. Like Bobby, I saw Bobby and Marvin and Valerie and a few other people. So thank you for letting us go. Yes, ma'am.
I got a question. Were they talking about, when we're speaking about good resources or good use of our resources and money these days, were there any mention of testing in low prevalence areas, any strategies geared towards that, and also any routine testing in clinical settings, trying to get the physicians buy-in and so forth? Because I sit on NATO's advisory board for the HIV prevention, and we're drafting a new policy statement, and that is inclusive of those 2 items. So I just wanted to know if they touched on any of those topics.
not that I heard, but if you want to talk about getting physicians involved, one of the people you need to talk to is Evelyn Ula, because she did a great job of that with Test Miami, getting a lot of the local physicians involved. The other thing about testing in low prevalence areas, I think everything that they're doing is going against the stream on that, because they're trying to test in high prevalence areas now, because they're still thinking that and I agree, which is what I start off by saying, I think that there's still a lot of people that we're missing in high prevalence areas that feel as though they're not, I mean, even when we were watching that video, you know, a couple of them said, I didn't think I would be, I didn't think I was had any risk, you know. So, none that I heard, I mean.
I think, can I talk?
Please do.
So I was at HPLS as well, and I went to heavily on the E-chip sessions, because E-chip was kind of new, and so that's how I spent most of my time there. But I also tried to cover as much of the testing and some of the other sessions as I could. And I think that CDC is still holding firm on the guidelines that they released in 2006, which is routine testing, opt-out routine testing in clinical settings. And they don't really make a distinction. I mean, they say that should be done, you know, everywhere in the country. However, the difference, I think, what they're looking at is that in lower prevalence areas, once you test everybody that one time, then future testing should be based on both individual risk as well as the overall prevalence of the jurisdiction. So I think that's where the differences come in. So our recommendations, if you're a gay man in Fort Lauderdale, our recommendations for testing are going to be very, very different than if you are a straight, you know, older woman in Sumter County. The recommendations are going to be really different. So I don't think it's a matter of do it or don't do it. I think the difference is how you do it, how often you do it, and what are the messages that are out there. But I think if we're ever going to normalize HIV, if we're ever going to get past the stigma, the last thing I think we want to do is say only people who live in inner cities are the ones that need to get tested and forget about everybody else. That defeats the whole purpose of the guidelines. The guidelines is that HIV should be normal and routine, and everybody should know their status. So if you're 22 years old, you get a test, you know your status, you're negative, and then, you know, you join the convent, and, you know, you have no reason to worry, you're done. You know your status. I think that's the point. But as soon as you do something that potentially could expose you to HIV, then you need to get tested again. So I think even though they have this broad approach about test everybody, it still needs to be customized and targeted for your jurisdiction and your area. There's no one-size-fits-all approach. And I think that's the take-home message that I got at HPLS and that I continue to get from the literature and studies and, you know, experience here in Florida.
And Marlene, maybe I'm mistaken, but they were talking about wrapping up testing in much more higher prevalence areas. At least some of the things I heard them. Or
Oh,
maybe I
absolutely.
misunderstood,
I mean, there's no question the overlay is about scalability. You know, I mean, there's no question that if in the 12 cities and in other urban areas that aren't, you know, maybe like the next 12 cities on the list, for example, there needs to be complete ramp up of testing with not only this overlay of test everybody in clinical settings, but this massive effort towards targeted testing, you know, that has social marketing, that has condom distribution, that has outreach, that, you know, all that whole package. You know, it looks very different in the urban areas than it does in the non-urban areas. But, you know, the key important message, and I think for the guidelines you're working on, Crystal, and for the work that everybody does, is it's about knowing your status. And then, you know, how often you have to test really is just a, you know, a very individualized assessment that needs to be made by you and your provider.
Quick update. I just want to give folks a quick update on a couple of things, and especially related to the questions, because the AIDS Institute was awarded a 5-year cooperative agreement from the CDC, and one of our activities is to produce the HPLS, or HIV Prevention Leadership Summit. That meeting has been produced by National Minority AIDS Council for the past 15 years, so we work closely with them and subcontract with them to help us produce this year's meeting in December. We produced this again in 2012. And what we wanted to share with you is one of the things is we're lobbying for that meeting to come to Florida. It'll be spring of next year. And All of the presentations from the December meeting are on our website, so you have access to them and you can get a lot of information. If there's something on there that you don't see, let us know. But we're going to continue doing this. We're also, as part of our activities this year with the CDC, we're running a CDC track at USCA, or United States Conference on AIDS, that's going to be in Chicago this year. So for the first time ever, there will be a full track just for CDC issues. There's going to be a lot of up-to-date information. We're pressuring them to get the incidence numbers out by then, so that we can have a lot of discussion and have maybe even a town hall meeting on the numbers, which we have pegged for them. But that's in November of 11. And as you know, this group sent Bobby and Charles and Valerie Mincy to this meeting.